Here at a cornea practice, we see a lot of abnormal corneas with irregular astigmatism, scarring, and as a result, it's higher order aberrations that make it where it's difficult to correct their vision with standard practices like cataract surgery or a pair of glasses. We often notice in clinic these patients improve significantly with a pinhole when we check their vision. And so oftentimes we found that pinhole pupilloplasty can improve these patients' visions via a surgical method. I'm Philip Dockery, and I'm going to walk you through the technique that we use for pupilloplasties, the reverse single pass 4th-row pinhole pupilloplasty. And so this case, it was after cataract surgery was performed. We dilated the patient with phenylephrine only, and then after the cataract surgery was completed, we constricted the pupil with myostat. I'm going in with a 10-0 Prolene suture on a long curved needle, gently sweep it through the main wound, go down through the iris stroma near the pupillary margin, and then come directly up across the pupil, again near the pupillary margin, and then exit through the cornea, not through a paracentesis. So there's no need for docking of sutures. We can directly exit the cornea with the needle. Pull it through, and then we use a push-pull to retrieve the distal end of the needle, or the distal end of the suture, pull it out through the main wound, and then do 4 throws of the suture tail through the loop that we pulled out. And then after that 4th throw, that no more tying is involved, we simply grab the distal end of the suture and then pull it to tighten the pupil. And you can see here the pupil is already much smaller just with one suture. We go in with our intraocular scissors to cut the suture, preferably at a 90-degree angle through a paracentesis. This allows for the most easiest cutting of sutures with lowering the risk of nicking the iris. In this case, we needed a second suture to try to close that pupil just a little bit more to provide the best pinhole effect. And again, sweeping through that main wound to make sure you're not creating an alternate track, and then going through near the pupillary margin, diving down through the iris, and then up through the iris near the pupillary margin again at the distal portion. I can provide some counter traction with my forceps to push it through the cornea. Again, not having to dock the suture with a needle, just pulling it directly out. And so after that's done, repeat the same steps by using a push-pull to grab the distal portion of the suture and pull it back through the main wound. And then again, using 4 throws of the proximal tip of the suture and through that loop that we had pulled through the main wound. And then gently pull the sutures tight. No more knots involved. We see here that the pupil is a little bit smaller than we would like for it to be. And so we can, at this point, instead of untying and retying sutures, we can actually reshape the suture using a cautery device on our phacoemulsification machine. And so this is for intraocular capsulotomy. And so we go in and we apply a little bit of heat in the iris stroma near the pupillary margin, but not at it. This contracts the pupil so that it forms a better shape for this patient. And thanks for joining us. See you next time.